Welcome back, everyone. Research Works podcast here at the pre-conference workshop at EACD-IAACD 2025. There's a lot of acronyms there, aren't they?
Yeah.
And with me, we have a friend of the show, the ever so popular. Your episodes go off, Cathy.
Really?
Yeah, yep. So Dr. Cathy Morgan, everyone, or actually Adjunct Associate Professor.
I know.
Yes,
yeah.
University
New
of
title this
Sydney,
year.
Cerebral Palsy Research Alliance Institute. Congratulations.
Thank
It's a
you.
great title.
Yeah, it's got a mouthful. I'm still Cathy, really.
Yeah. Well, Cathy, every time we have spoken, there's always been great interest in what you have to say because everyone is really interested in early intervention and what to do. And I think that's a great reflection on what therapists are wanting and wanting to do. So from your perspective at the moment, what is the current state of early intervention? What would you say? Because I feel like a lot has happened.
Yeah. I think a lot's happened in the last 10 years or so. So we had this summit actually at the EACD in 2014. And at that summit, we brought together people from all over the world who were actively doing early detection and early intervention research. We brought everybody together, and that's where the two guidelines really eventuated from. But I have been reflecting that since that time, you know, it's so expanded, the volume of work that's being done around the world. And, you know, things that were kind of in their infancy around, no pun intended for infancy, but about constraint back then, for example. Now we found in the GAME trial, in usual care, 62% of the babies who had a hemiplegia in the usual care group had constraint-induced movement therapy in Australia. And so I think, you know, the uptake of good practice is taking off. And, I think it's so important to remember that's why we're doing research. At the end of the day, it's to inform clinical practice. And clinicians have then got the responsibility to try to take that on and implement those findings in their work. So I'm so glad to see that that's happening. And I'm glad to see the volume of work that's being done. And I think there's been so much focus on motor, you know, bimanual constraint, task-specific training is getting a lot more airplay than it did 10 years ago.
Right?
I know, isn't it great? But there are more things to think about, you know, cognition, social, emotional well-being of infants, the attachment stuff, parent-child relationship. I think all of these things have been important to, you know, psychologists, social workers, and some parts of educators. And now we're really starting to realise how very important it is to build there, and also to help parents be engaged in early intervention, to be at the just right challenge for them as well, really, because they've got a lot going on. So I think the field's really moving to explore more areas of early intervention, and I think the therapists are actually starting to really take heed and change their practice. Certainly in Australia. I don't really know a lot about the rest of the world, but it's thrilling to see that in Australia.
And I suppose we did talk about that last time, didn't we, with GAME, is that was a big reflection point, was that evidence-based interventions are happening.
And I think
they're doing it.
I think with some of the things that have helped in Australia with the NDIS and all of those things means that there's money available for families to be able to access intervention. Not that it's always great intervention that's been accessed, but there's a lot of good intervention.
That's right.
I think that's fantastic.
And it's really great to focus on those, isn't there? Because there are obviously, and we've spoken about them before, there's just better ways to do things, and we're at that place now where we can actually be so specific about what they are. So that's, in terms of early intervention, it feels like it's the way I would summarize how I just heard it was, it's just more holistic. Because we were so siloed, weren't we? It was very motor based, but from there, all I hear now is making sure we're looking at the family as a whole, and you are thinking about cognition, whereas I feel like cognition wasn't even brought into the conversation.
Well, you know, in 2014, when we invited people to that summit, we looked really hard for someone who was doing cognition research in early intervention in brain-injured children. There was a bunch of experimental psychology stuff going on, and has been for many, many years, but really saying, what are the strategies we use to build cognition in a baby with CP? There was nothing, and we couldn't get someone to come and do that. So I think the closest we got was Reggie Harborn and all her work, you know, looking at cognition and motor together, which was obviously brilliant. But I think that's starting to shift as well. And communication's another one, feeding. You know,
there were areas where it was very unknown, but so vital.
Exactly.
So vital. So your work that you're involved with a lot at the moment is very topical when it comes to worldly conversations about artificial intelligence. I feel like that is on the tip of everyone's tongue, is this whole AI thing, what is that about? So how are you incorporating AI into the work that you're doing, Cathy?
Well, it's not so much in the early intervention. So we shift into early detection, which is my other very favourite area, where we're just really trying to bring that age of detection or diagnosis of cerebral palsy down. So we know that in Australia, less than half of children get diagnosed by 1.
Yeah.
And only 25% by about 6 months.
Wow,
and so, you know, if you think about the time from the brain injury to when they may start early intervention, this is too long.
Yeah.
We would not put up with it with adults.
No, you're absolutely right.
And so the early detection part is actually critical, because we think the earlier and the closer to the timing of the injury, the better the outcomes are going to be. And also it provides that support for families. So to get early detection sort of happening at, I guess, at a greater level, I think we're screening maybe 10 to 20% of all kids who are going to have CP. Right. So we're missing probably 80% of them. Yeah. Oh. So even though every NICU uses the best available tools now, they only screen a proportion of the children because they don't have the resources to do it. Right.
I see. Okay.
And so in order to get screening, at least for the most high-risk babies, say every NICU infant, we need to change the paradigm somehow.
Yeah.
And so what we've been doing is developing AI models, not just me, but obviously I'm not a computer scientist. I actually don't develop them, but I'm working with them.
Yeah.
Yes. Very clever computer scientists and engineers who are looking at best practice machine learning processes to try to help a computer understand what fidgety movements are and when they are and aren't there.
Right.
Right. So this is requiring lots and lots of data, lots and lots of videos, lots and lots of labeling. And so, you know, there's been many, many groups around the world that have started on this journey thinking it was going to be easy. But in fact, it ends up not being quite so easy. And people train models on a certain number of videos, and then when you put new videos in there, your accuracy drops. And so there's this kind of iteration that goes on where people can never get to the right level. So what we needed was to bring people together to say, let's harmonise how we do this.
Yes.
And CP360, I don't know if you've heard of that. Yeah, so CP360 is a global movement for cerebral palsy. And one of the first areas that we're looking at is the first 1,000 days. And one of the groups within the first 1,000 days is this group trying to say, how can we make screening for cerebral palsy more universal? Brilliant. And so we're starting with trying to get an AI, I guess, process that can be built collaboratively through a network of people who trust each other. And so, you know, no money's come into this so far. It's all been goodwill and people being willing to cooperate. And so we've come a long way. We've got a paper going to be published very soon on what the roadmap looks like for that.
Brilliant.
And I think it's a really exciting field, and we hope to be able to make really substantial gains in the next 5 years.
Wow. And when you think about the potential impact this could make, it is huge, isn't it? It changes the landscape once again, absolutely. What are some of the, I guess, for people to understand, because I do think AI sometimes just sounds like it's a little bit magical thinking sometimes, isn't it?
And it sounds a bit scary.
Yeah, it's just, this just goes in and it comes out. So what are some of the challenges that need to be considered when developing these AI models?
Yeah, well, I think that the number one concern that everyone has is privacy. And when you're talking about the general movements, for example, there's a video of a little baby who belongs to somebody who really loves them. And when they've consented to that video, they haven't generally consented to having their baby's video join into some sort of AI algorithm. And so there's that whole managing that moment.
New process, really, isn't it?
It is a new process, and you know they're in a very special time of their life when this is all happening. So mostly we've got lots of videos. Everybody's got them in their research cohorts or their clinical cohorts, but we don't have permission to share them.
Okay.
And of course, machine learning requires more and more data to refine and refine and refine and refine.
Yeah.
So one of our biggest problems is getting enough videos.
Okay.
Kind of got a few ideas there, because what's extracted from a video is like a skeleton figure.
Right.
And so that's completely de-identified.
Right, okay.
And so we've got options, but we have to work out how we can do that.
Yeah.
So that's one of the challenges. So the amount of data, the consent process, the idea of IP and who owns what IP, and then when you collaborate together, you know, site A has this algorithm, site B has that algorithm, and which one's going to work best. And so there are various ways that we can work together to have all the algorithms in one central place and then being sent out and being trained to data sets and then coming back in. And so these very clever people talk about federated learning models and things like that.
Wow.
So there's been the kind of the collaboration piece, there's been the consent piece, there's been getting the amount of data piece.
How much data is needed? I mean, is there a number that
we had a number, but it's really ballpark. The other day, somebody had done some work looking at other diseases, and because we've got, you know, in a cohort of GM's videos, usually 85% of them are normal and 15% are abnormal. And for really good models, you want 50-50, and it's very hard to get to that, right? So there's issues related to that as well. So I think we've worked out probably about 25,000 videos that are labelled with extracted data. So I think between us, we've worked out we've probably got like maybe 15,000 or something.
Right.
But they're not all got consent to share with each other. So they're all sitting in our own labs. So, you know, there's work underway. We've had some wonderful legal advice about how we can sort of optimise this process. And but it's a lot. There's a lot of little working groups working on the AI side and then the governance side to try to
amazing.
To get
this is why research is done in teams, and it's best done in teams. What's the level of accuracy would you be aiming for? Like, what's the current acceptable amount for like a human to rate it? What's
so what we find in general movements training is that we get sort of inter-rater reliability around the 90 to 93%, right? And so what we were hoping to get is around 90% agreement. So it's not a diagnosis. I think that's important. So 90% agreement between a human scorer and the machine. I think a lot of people get into the 80s, but getting from the mid 80s to the 90s on new data that you bring into your algorithm is proving quite hard. So, you know, people are so clever and they just keep working away, banging away at it, and they feel confident that it's going to happen. But I think it's going to always be a slight triage system where the algorithm built into an app would say, actually, this baby is at high risk and they need follow-up. And then, it's not going to give them the diagnosis at that time, but it's going to say, actually, we need to see this baby again. But, you know, in the GMs, there aren't that many false positives or false negatives. There's always a few in every test. So we're wanting it to get to it to be pretty robust because the information that you give from these, you know, GM's assessment is pretty important. So,
and I can imagine this would be something that could be quite scalable with thinking about, you know, low middle income countries.
Absolutely.
So what's the
aim?
What does that look like?
So we do. I think this group, the CP360 group that have worked together, and I just wanted to shout out to Alicia Spittle, who's kind of really coordinated that, and Andrea Gazzetta, Deidre Murray from Ireland have all worked really hard on this process, along with the engineers from Deakin and Murdoch and everywhere. I think we want to get to a point where this is, I mean, someone's got to pay something for it, but we don't want it to be a cost to low and middle income settings. So we'd love to have a clinical version of an app that takes video with the algorithms built in, and someone can use it within a clinical setting, a community worker. But we want to stay connected to clinical services too, because having that kind of information without a person to help interpret it and explain,
at a very vulnerable time.
At a very vulnerable time. But we do want this to be available broadly, not a cost to people.
And that's the 5-year plan, was it? Is that what you said before?
Well, I don't think getting it to LMICs is the 5-year plan. I think the 5-year plan is to really have a viable algorithm that's really quite accurate.
It's very exciting. Very, very exciting.
It is.
So for all of our listeners who are listening, mostly researchers and clinicians, Cathy, what is the one thing that you really want people who've been listening to what we've spoken about today to really take home and think about in their day-to-day practice?
I think it would be that early intervention is critical for the baby, it's critical for the parent, and we've got to be able to find the babies early using robust measures. So the whole pieces have to come together. You can't get early intervention if you don't have good, robust ways of identifying the right kids, because early intervention is diagnosis specific. What you do for a kid with ASD is different to what you will do for a child with CP, and even within the CP group, Hemi is going to have something different to a child who's affected bilaterally or who is dyskinetic. And so just be really aware of who is in front of you. And the context in which they
Beautiful.
come to you.
Yeah,
in.
I love that. Thank you, Cathy. Thank
My
you so much
pleasure.
for sharing and about the new research. It's always very exciting.
Yeah.
It's just wonderful to hear how so many groups are coming together, and how amazing is it from a summit in 2014?
Yeah.
That wasn't that long ago.
No.
And what has happened
in the country
then?
next door.
Oh my goodness, it's amazing. Absolutely amazing.
It
and it just shows there's so much value in bringing people together to work together in a common cause. So it's amazing to watch and be part of in terms of the whole process of implementation now. So gosh, guys, I hope you really enjoyed that. We have so much more to cover. Obviously, this is just pre-conference workshop. There's so much more to come within the whole conference itself. So please get in touch if you've got any questions. We're right here, and I hope you enjoy all the content. So we'll talk to you all again really soon. Bye.